Okay, people, are you ready to dive into the DSM-5? Ready or not, here we go. This is gonna be a quick run through of the DSM-5, mostly highlighting what to expect on the exam. Much of the work is going to be done after the video where you focus on the criteria pages, but I'll give you some tips in these two videos. So DSM-5 first published in 2013. There was a minor update in 2018, mostly coding and clarifying specifiers. Nothing to worry about for the exam in that. There's a helpful link at the bottom of the DSM-5 review page to YouTube videos. If you want more help in understanding some of the different diagnoses, there's some nice YouTube video links. Also, this PowerPoint is found at the bottom of this video page. So you're going to want to download the PowerPoint. That can also be helpful in your studies. I will often refer to helpful pages found in the intake and assessment study document. You'll be downloading this from the intake assessment and diagnosis page. It's one of the 5 primary content study documents for my program. Following is a summary of those diagnoses most likely to appear on the NCMH-CE. The exam is going to focus on the common bread and butter diagnoses. Some of the really rare stuff is super unlikely on the exam. Refer to your DSM-5 for full diagnostic criteria. Now, the DSM-5 is many's of pages. You do not need to read your entire DSM-5 for this test. You can read it for your own personal edification if you want, but you don't need it for the test. What you need is the criteria pages. That's what they're going to be testing you on. So know your criteria well. In this program of mine, I've got a number of mnemonics that help for the ones that are more important to memorize. For many of them, it's more about just being comfortable with, which is a step down from memorizing. So you're going to focus on the criteria pages. And then for differential diagnoses, really the most efficient way to do those is just to be able to think categorically. So there are a number of disorders that have similarities. Those would all be within the same category, and they would therefore be potential differential diagnoses. So when you get lists on the exam and ask which one would not be an appropriate differential diagnosis, I mean, you can memorize if you want. I'm not a big fan of memorizing. More so, just look at those lists and see which one doesn't belong, which one doesn't have features that are similar and overlap with the diagnosis in question. So now we're just going to start running through the different diagnoses. I've mapped these out in the order that they are presented in the DSM-5. It starts with neurodevelopmental disorders. These include intellectual disabilities, communication disorders, autism spectrum disorder, ADHD specific learning disorder, motor disorders, and other. Intellectual disabilities, what we used to refer to as mental retardation, specifiers mild, moderate, severe, profound. On the exam, you do need to be familiar with how specifiers work. Again, that's not memorizing them, but do know how they work with the different diagnoses. So with intellectual, you've got mild, moderate, severe, profound. It is now based on functioning, not on just an IQ test. Not likely on the exam, but you should be familiar and know the new language. Communication disorders, there are several. Language disorder, that has to do with acquisition and use. Speech sound disorder, the production of speech. Childhood onset fluency disorder, that would be stuttering. Social pragmatic communication disorder. This is where someone does not understand social norms in communication. They can't read verbal and nonverbal cues. They drone on and on and on, not realizing that their audience has stopped listening. You're still listening, right? Autism has this communication piece plus the restricted and repetitive behaviors and interests piece. Autism spectrum disorder, the impaired social interaction and communication in multiple contexts, restricted repetitive patterns of behavior, interests, or activities, onset in the early developmental period, and of course, Asperger's has been removed from the DSM-5. Attention deficit hyperactivity disorder, super common on the test. Inattention and or hyperactivity/impulsivity, symptoms present before age 12, impairment present in at least 2 settings. Specific learning disorders, these are also common on the test. Reading, written expression, mathematics. They are not uncommon on the exam. Well, that's kind of NVCC language, Johnny. They are common on the exam. You want to watch carefully, though, if they're describing something and then ask which is the most appropriate diagnosis. Don't just choose the first learning disorder if it's a learning disorder. They may have thrown a reading disorder up first when the actual correct answer is a written expression learning disorder. Motor disorders, developmental coordination disorder, stereotypic movement disorder. This one is like autism but without the social interactive disability. Tourette's, persistent motor or vocal tic disorder. Schizophrenia, next section up, schizophrenia, spectrum, and other psychotic disorders. These include schizotypal personality disorder, delusional disorder, brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder, and substance/medication-induced psychotic disorders. These lists here are helpful in terms of when I was talking about categorical thinking. These are all going to have overlap if they're in the same category. First up, pop quiz. These are designed just to give you a little gauge. I think we tend to think that we know our DSM-5 pretty well, but there are some challenging differentials, so I've got some pop quizzes in here just to help you to see how good you are at the DSM-5, how much work do you actually need to put into those criteria pages that we are talking about. So clinical scenario number 1, or pop quiz, whatever you prefer. Mr. Horn is a 45-year-old new client who presents to your private practice. He explains that his wife wanted him to talk with someone. When you question this, he explains that for the last 5 months, there's a duration, someone has been following him. He walks to work each day and is sure that he is being stalked. When you ask him to describe the stalker, he explains that it must be a spy who is a master of disguise because the stalker looks different every time. He says that his wife says she is tired of hearing about the spy. Based on the information obtained about Mr. Horn, which of the following is the best provisional DSM-5 diagnosis? Choose only one, and as with the exam, you've got 4 choices with 1 right answer. Is it generalized anxiety disorder, schizophreniform disorder, delusional disorder, or paranoid personality disorder? Go ahead and pause the video while you make your choice. When you have made your choice, unpause the video, and I will click to the next slide. 3, 2, 1. The right answer is Mr. Horn has classic delusional disorder. Did you get it right? Hope so. So one by one, we've got schizotypal personality disorder. This has features of both schizophrenia and a personality disorder. Social discomfort with cognitive and or perceptual distortions is kind of the hallmark of schizotypal personality disorder. Delusional disorder, also known as Mr. Horn's disorder. 1 month or more, pay attention to durations of delusions, plausible but not real. For example, you believe your spouse is being unfaithful or you're being followed. Used to say non-bizarre, that's been dropped. They can be bizarre. The subject doesn't meet criteria for schizophrenia. Function is not markedly impaired. Behavior is not obviously bizarre or odd. So this basically, you look at Mr. Horn, he's walking to work. He's still able to hold down a job. So the behavior isn't obviously bizarre. The delusion, who's to say what's bizarre or not? So they dropped that. So he thinks there's a master spy following him. Is that bizarre? You tell me. I don't know. It's a delusion. So there's different types of delusional specifiers. When you go through your DSM-5 criteria, pay attention to the specifiers for Mr. Horn disorder. Then there's brief psychotic disorder. Name says it all. A psychotic disturbance that lasts less than 1 month. Schizophreniform disorder, similar symptoms to schizophrenia, but it's between 1 to 6 months, and it does not require the social occupational impairment. Essentially, schizophrenia has a 6-month minimum duration. What do you diagnose someone with when they are they're moving towards that? It's been 3-4 months, and you haven't reached that threshold yet for schizophrenia. You diagnose them with schizophreniform. Schizophrenia lasts at least 6 months, has social or occupational dysfunction, and at least 1 or more active symptoms, including 2 or more, has at least 1 month of active symptoms, including 2 or more of delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms, flat affect, eulogia, etc. Then there's schizoaffective disorder, major depressive or manic episodes, along with 2 or more active symptoms of schizophrenia. At least 2 weeks of delusions or hallucinations in the absence of prominent mood symptoms. Otherwise, if the delusions or hallucinations only occur during the manic or depressive episodes, then consider one of the mood disorders with psychotic features. Guess what I have? A helpful summary chart for the schizophrenia spectrum and other psychotic disorders. You will find it in the study document for the intake assessment diagnosis domain. I've got a number of these helpful study charts in that document. Time for our second pop quiz, clinical scenario number 2. This is Ms. Blackman. She is a 38-year-old who has been struggling with symptoms of depression for 3 months. Her doctor is trying her on a second trial of an antidepressant medication since the first trial did not seem to help her depression. But she reports that it doesn't seem to be helping much. She pauses and then adds that maybe it is helping. She did have 4 days last week when she felt, quote, energized, quote. She was able to get lots of work done and didn't seem to need much sleep, hint, hint. Unfortunately, she is back to feeling low again. Based on the information obtained about Ms. Blackman, which of the following is the best provisional DSM-5 diagnosis? Choose only one. Your 4 choices are major depressive disorder, bipolar 1, bipolar 2, or cyclothymic. Go ahead and pause the video, make your choice, and then I will uncover the correct answer. And the correct answer is bipolar 2. Did you get it? Did you get it? Which brings up the next category, which is the bipolar and related disorders, bipolar 1, bipolar 2, and cyclothymic. Manic episodes, abnormally elevated, expansive, or irritable mood lasting at least a week unless the person is hospitalized. If their manic episode is severe enough to the point where they have to be hospitalized on day 3, that still counts as a manic, even if by day 4 it's been resolved with medication. So if they're hospitalized, that counts. Manic episodes include 3 or more of the following: inflated self-esteem or grandiosity, decreased need for sleep, more talkative than usual, racing thoughts, distractibility, increase in goal-directed activity or psychomotor agitation, excessive involvement in pleasurable activities with disregard for negative consequences, significant impairment in social/work functionings. The manic episodes can include psychotic features, and some of you may know the mnemonic dig fast. You will find it in the intake/assessment study document. Hypomanic episodes. These are persistent, elevated, expansive, or irritable mood lasting at least 4 days. So shorter threshold than a full manic, hence the name hypomanic. So if someone has 2 weeks, is that a hypermanic? No. Nope. Just manic. Same symptom list as manic episode, except no psychotic features. Bipolar 1 disorder, 1 or more manic episodes, significant impairment, and can involve psychoses. Bipolar 2 is 1 or more hypomanic episodes, no manic episodes, and 1 or more major depressive episode. Cyclothymic disorder is chronic fluctuating mood disturbance involving numerous periods of hypomania and depressive symptoms that don't meet full criteria. 2-year period, 1 year for youth. So you don't have a manic, hypomanic, or major depressive episodes, but you're close. So, this long-term cyclothymic struggle. Another one of my helpful summary charts, this one for the bipolar and related disorders in the intake assessment document. Brings us to depressive disorders. We've got disruptive mood dysregulation disorder, DMDD, major depressive disorder, persistent depressive disorder or dysthymia, premenstrual dysphoric disorder, and unspecified depressive disorder. DMDD is severe recurrent temper outbursts that are out of proportion to the situation. The outbursts are inconsistent with the client's developmental level. They average 3 or more times a week. In between these episodes, the client is persistently irritable or angry in their mood. That's kind of their default setting. 12-month minimum duration seen in multiple settings, and the initial diagnosis occurs between ages 6 and 16. We do not diagnose tantruming toddlers with DMDD, or they would all have it. Major depressive episode. 5 or more of the following over a 2-week period. Again, duration, 2-week period. Depressed, minimum duration. Depressed mood. In minors, it can occur as irritability or anger. Diminished interest and pleasure, significant weight loss in minors, consider failure to meet expected weight gains, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feelings of worthlessness or guilt, cognitive impairment, recurrent thoughts of death or suicide, and again a common mnemonic, SIG-E caps, found in the study document we keep referring to. So it's a major depressive disorder. It's when you've got 1 or more major depressive episodes. Persistent depressive disorder, dysthymia. This is depressed mood for at least 2 years. For minors, 1 year at least. Includes 2 or more of the following: poor appetite or overeating, insomnia or hypersomnia, fatigue, low self-esteem, cognitive impairment, feelings of hopelessness, no manic or hypomanic episodes during the 2-year period, no cyclothymia, but can have chronic depression. So those are your criteria for persistent depressive disorder. Premenstrual dysphoric disorder, I'll just read through them. 5 or more of the following premenstrual symptoms: marked affective lability, marked irritability, anger or increased conflicts, depressed mood, feelings of hopelessness, anxiety, tension, edginess, decreased interest in activities, difficulty in concentrating, lethargy, change in appetite, overeating, food cravings, hypersomnia or insomnia, feeling overwhelmed or out of control, physical symptoms such as breast tenderness, joint or muscle pain, bloating, etc. Must include clinically significant distress and occurring in most menstrual cycles in the past year. I have a nice chart, summary chart for the depressive disorders in that study document. Which brings us to pop quiz number 3. Under anxiety disorders, we have Mr. Bush. He has been a client for 2 months. He struggles with the fear of being in social settings where he may feel trapped. He worries that he won't be able to get away if he needs to. He does not have a history of panic attacks. You have been helping him with slow, progressive, systematic desensitization. And your choices are panic disorder, agoraphobia, generalized anxiety disorder, or social anxiety disorder, parenthesis, social phobia. Which one is it? Pause your video, make your choice. And the right answer is, this one, it's a tough call between two. It is agoraphobia. You'll see why as we get to the criteria. So the anxiety disorders, helpful list to know. So separation anxiety disorder, selective mutism, specific phobia, for example, flying, heights, animals, blood, social anxiety disorder or social phobia, panic disorder, agoraphobia, and generalized anxiety disorder, GAD. Separation anxiety disorder, excessive anxiety concerning separation. Go figure. At least a 4-week duration. See the DSM-5 for full criteria description. Selective mutism as an anxiety disorder, remember that. Consistent failure to speak in settings where there is an expectation for speaking, for instance in school, despite speaking in other settings. At least 1 month minimum duration. Specific phobia, marked and persistent fear of clearly discernible objects or situations. Exposure provokes fear or anxiety. Avoidance or endurance with intense fear or anxiety. Response is out of proportion. Persistent, typically lasting 6 months or more. That is not a hard duration. When it says typically lasting, that is not a hard duration. There are 5 subtypes. Animal type, natural environment type, blood injection injury type, situational type, which, by the way, includes anxiety regarding examinations, and then other. Social anxiety disorder, this is one of the 2 that you might have been teasing between for Mr. Bush. Social phobia. Marked fear or anxiety of social situations in which the individual is exposed to possible scrutiny. In children, the anxiety must occur with peers, not just adults. Fear, there's a fear of negative evaluation, and these words are in bold: humiliation, embarrassment, or rejection. Now you notice with Mr. Bush, he wasn't afraid of humiliation, he was afraid of not being able to escape, and that's the hallmark difference here. So for social anxiety, it's about fear of negative evaluation. Exposure provokes fear or anxiety. Avoidance or endurance with intense fear or anxiety. Response is out of proportion and persistent, typically lasting 6 months or more. Criteria for panic attacks. Intense fear or discomfort develops rapidly, peaks within minutes. We got adrenaline on board, includes 4 or more of. Palpitations or increased heart rate, sweating, trembling, shortness of breath, feeling of choking, chest pain, nausea. Sounds like a side effects may include commercial. Chest pain, nausea, dizziness, chills or heat, numbing or tingling, derealization, including blanking out, fear of losing control, going crazy, or dying. Panic disorder continued. So panic disorder, so that was a panic attack. Panic disorder is recurrent unexpected panic attacks. At least one of the attacks has been followed by at least 1 month of at least one of these guys here, a persistent concern about having additional attacks or their consequences, or significant maladaptive behavioral change related to the attacks. And now agoraphobia, marked fear or anxiety about two or more of using public transportation, being in open spaces, being in enclosed spaces, standing in line or being in a crowd, being outside the home alone, fear or avoidance due to thoughts that escape might be difficult or help not available. That's the difference between, one of the differences between agoraphobia and social phobia. Thoughts that escape might be difficult. Exposure provokes fear or anxiety. Exposure is avoided, requires companion, or is endured with intense fear or anxiety. It's out of proportion, and it typically lasts, again, not a hard duration, typically lasting 6 months or more. And then GAD, excessive anxiety and worry, at least 6 months minimum duration, more days than not experiencing this. Trouble controlling the worry includes 2 or more of the following, 1 or more for children: restlessness, fatigue, difficulty concentrating, mind going blank, irritability, muscle tension, sleep disturbance. Clinically significant distress or impairment, and I have a mnemonic for GAD in the study document that we've been talking about. So teasing out social anxiety versus agoraphobia versus panic. Social anxiety disorder focus is on fear of social embarrassment, humiliation, or rejection. Agoraphobia focuses on anxiety about escape or having panic-like symptoms rather than full panic attacks. And then panic disorder, full panic attacks with at least a month of worry. Next up, the obsessive-compulsive and related disorders. We've got obsessive-compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling, and excoriation, which is skin picking disorder. OCD, the presence of obsessions, compulsions, or both. Obsessions are defined by recurrent, persistent thoughts, urges, or images that are intrusive and unwanted. Attempts to ignore or suppress or neutralize these thoughts. Compulsions are defined by repetitive behaviors or mental acts that a person feels driven to perform, unrealistically aimed at preventing or reducing anxiety or distress or preventing a dreaded event. The obsessions or compulsions are time-consuming. And then body dysmorphic disorder, preoccupation with imagined defect in appearance, repetitive behaviors or mental acts related to this, and significant distress or impairment. Hoarding disorder, difficulty discarding items regardless of their value, perceived need to save, distress associated with discarding items, congested living area, unless others are around consistently throwing things out for the subject, and significant distress or impairment. Trichotillomania and excoriation are not very likely on the exam, but you can be generally familiar with them. They both require repeated attempts to stop and clinically significant distress or impairment. Next, we have the trauma and stressor-related disorders. I like the way that the DSM-5 has grouped these together: reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, acute stress disorder, and adjustment disorders. Reactive attachment disorder, markedly disturbed, withdrawn attachment behaviors. A number of criteria. Go ahead and look those up in your DSM-5 for the full criteria list for reactive attachment disorder. Yeah, may or may not be on the test. Disinhibited social engagement disorder, overly familiar behavior with strangers. This one is similar to what used to be the reactive attachment disorder disinhibited type. They've created its own category now as disinhibited social engagement disorder. Again, see your DSM-5 for full criteria. PTSD, exposure to trauma, either direct or vicarious. You have intrusion symptoms, memories, dreams, flashbacks, physical and emotional distress, avoidance of associated stimuli, negative changes in cognitions and mood, alterations in arousal and reactivity. The duration is over 1 month, and DSM-5 has a more complete list of criteria. There's also a mnemonic in the intake assessment diagnosis study document. Acute stress disorder. So PTSD has a minimum 1 month duration. What do you do when it's only been 2.5 weeks? Acute stress disorder, the development of characteristic anxiety, dissociative, and other symptoms that occurs within 1 month after exposure to an extreme traumatic stressor. The traumatic event is persistently re-experienced, avoidance of associated stimuli and numbing of responsiveness, increased arousal, duration between 3 days and 1 month. And then adjustment disorders, super common on the test. Clinically significant emotional or behavioral symptoms in response to an identifiable psychosocial stressor or stressors. Symptoms must develop within 3 months. Marked distress, more than expected, or significant impairment. It's not bereavement. Bereavement is its own thing. And it says resolves within 6 months from end of stressor, but many of the stressors for adjustment disorders don't end. So your parents are divorcing. There's not an end date to that. They're divorced. There's not an end date to that. Otherwise, use other specified trauma and stressor-related disorder per 2018 update. Don't worry about that. Yeah, don't worry about that. Up next is dissociative disorders. Its DSM stuff is brain drainy, so let's take a break here and I'll cut the video and start the next video with the dissociative disorders so that your brain doesn't get too mushy. Not too mushy. So I'll be right back.